98 when I was a student, or in 2006 when I was a resident. So that has been really incredible. So let me just do this. So we're going to talk about the different types of SMA. We're going to talk about a little bit about the genetics. We'll talk a little bit about the epidemiology, how frequent or how common is it. We're going to talk about the treatments, including gene therapy. So what is spinal muscular atrophy? So it's a motor neuron disease. And basically, it causes death of the anterior horn cells, like in many other motor neuron diseases. Because you have motor neuron involvement, you get muscle atrophy and weakness. And that affects both the cortical bulbar and the cortical spinal tracts. So therefore, not only do you get extremity weakness, but you get weakness of your bulbar muscles, of your facial muscles, of your speech muscles, and all that. It's an autosomal recessive disease. So you need to basically get one copy from each parent. In New York State, which I don't think I mentioned in this slide, it is now a newborn screening disease. So in other words, every baby who's born, right, there's a newborn screening panel for every state. And this is on New York State's screening panel. And I think it's also on the screening panels for 45 other states. So if you were born in the United States of America now, you will be diagnosed with SMA, including the type of SMA. We are a New York State SMA newborn screening site, which means if a baby is born in Brooklyn, Queens, and Staten Island, they are referred here for further management. And about 5.5 weeks ago, I got the email from Albany saying that we had a newborn who was just born with SMA type 1, which we'll get to about the different types of SMA. So unlike when I was a student or a resident or an attending, when you had to make the diagnosis on your own, and you still do for older people, right? Because newborn screening has only been around for 4 years. Now it's going to be done automatically, which has been a godsend, because we might get into one case of a baby who was missed and was not treated appropriately and on time. So it's the most common genetic cause of infant mortality in the US. And the incidence is actually pretty common. It's, I would say, probably 1 in 10,000. 1 in 6,000 is a bit much, maybe 1 in 10,000. So we're talking about 1 in 10,000 live births. Remember, both boys and girls. So this is a common diagnosis. Now, many of you guys, or some of you guys who are married or have kids, they now actually offer genetic testing. So they have these panels now when you get married, for different diseases. SMA is actually on many of those panels. And in fact, here at Downstate, the genetic counselor offers prospective parents the option of getting SMA carrier testing to see if you're a carrier for it. So this is the history of SMA. So it was reported by Verdig, I'm sure I butchered that name, in 1891. And then basically they finally got together and figured out that they saw many different types of SMA. It was the same disease, just different severities of SMA. So we used to use different names, Kugelberg-Wielandser and Verdig-Kaufman, but now we use SMA types 0, 1, 2, 3, and 4. Okay, so we've gotten rid of this Kugelberg-Wielandser description. So the only people who use that are neurologists who are like 100 years old. And my father. Yeah, no, I'm just joking. So maybe some of the more senior peds neuro attendings, but even like Dr. Geary and others, I think they really now use SMA types 1, 2, and 3. This is also when they discovered the genes. So it was about 30 years or so, they discovered the SMN gene. And this is when they started to do the different clinical trials. So with how to classify it, there are 2 ways of classifying it. So either you classify it genetically, in other words, how many copies you have of what we call SMN2, or you can classify it based on motor acquisition. In other words, what motor milestones are you able to achieve? So one of them is a genetic classification, and one of them is a clinical classification. So obviously, if you're a newborn, you can't do a clinical classification, right? Because you can't expect a 2-day-old to sit up and stand and do all the other motor milestones that you would normally use to classify. So for a newborn, we use genetic classification. But if you have a child, you can also use clinical classification. So, so this is basically, in many ways, the most important slide, because this tells you how it presents and what's the natural age of death, and how many copies do you have of SMN2? So SMA ranges from 0 to 4. Okay, it turns out there's probably a 1A and a 1B, but only for the people going into neuromuscular probably need to know that. So SMA type 0 is the worst. These are the ones who are at birth, they're born, they're floppy, they can't breathe on their own, they can't swallow, right? And they basically die very soon afterwards. Here they say less than a month. So they need respiratory support, they need a trach. It's very, very, very bad. That, luckily, I've only seen once in my life. And these people have one copy of SMN2. And just a brief aside, what is SMN2? So we all have SMN1, right? All of us have 2 copies of SMN1. It turns out even if you're a carrier for SMA and you only have 1 copy of SMN1, that's fine. You have no clinical manifestations. We also have SMN2. SMN2 is a protein that's homologous to SMN1. What does SMN1 do? We actually don't know what the protein does. All we know is when you don't have SMN1 protein, your motor neurons die. But it turns out SMN1 is all over the body. It's in the liver, it's in the motor neurons, it's in different parts. But it only seems that when you lack SMN1, only the motor neurons die. So we all have SMN2, don't know what that does. But basically for people who have SMA, who have no copies of SMN1, which is the definition of SMA, the more copies you have of SMN2, the less affected you are. The less affected the phenotype is. So as you'll see, going from the worst type to the mildest type, you see more and more copies of SMN2. And really the maximum is about 8 copies of SMN2. You know, obviously in normal people, we don't check SMN2 because you don't need it. So I don't know how many copies I have because who cares? All that matters is I have 2 copies of SMN1. So SMA type 0, they die very soon after birth. They have 1 copy. SMA type 1, they manifest anywhere from very shortly after birth till about 6 months. Their highest level of function is that they can sit only with supports. So without support, they can't even sit, but they don't die immediately. But if you don't treat them, they die at around age 2. About 90% die by age 2. And they have 2 copies of SMN2. SMA2, they usually manifest before 18 months of age. They're never able to stand. So in other words, they can sit, but they can't stand. So they can't really crawl. They obviously can't walk. And they die usually in childhood. And now what's interesting here is they can have 3 copies or 4 copies of SMN2. So sometimes you want to try to use the number of copies of SMN2 to tell you what type of SMA you have, but you see over here, there's some overlap between SMA type 2 and SMA type 3. You can have 3 or 4 copies of SMN2. And SMA type 3, usually they manifest anywhere between 1.5 years and 3 years. 3B is the milder type, which is even over 3 years. And they can pretty much do everything, stand, walk. But what happens is they start losing milestones, usually in their preteen or teen years. And they usually have a close to normal life expectancy. And they frequently will have 4 copies, either 3 or 4 copies of SMN2. And then finally, SMA4 is actually the one that applies to almost everybody here in the audience, at least all the adult neurology residents, because you're not going to see types 0, 1, 2, and 3 if you're an adult neurologist. But you may see SMA type 4 as an adult neurologist. So these are people who present usually 3rd, 4th, 5th decade of life, and they're going around, they had normal development, they're walking, they're fine, and then they start getting weak, usually proximal weakness. It's very tricky to diagnose because you're not thinking about an infantile or pediatric disease in adulthood. And as you guys well remember, since we just spoke about myopathies, there are many diseases out there that present with proximal weakness. So if somebody comes in with proximal weakness, you're not thinking motor neuron disease first and foremost. You're thinking myopathy or something like that. So now, obviously, if you do an EMG, you know, you will see what we call a neurogenic pattern on the EMG with loss of motor units, giant motor units. So you will make diagnosis if you stick a needle in a proximal muscle, but you need to actually do the EMG to make the diagnosis or think of it on your own and send genetic testing. So these are the different types. The baby who was just referred to me as type 1, and it turns out there's actually 1A and 1B. So 1A, they manifest usually the first month, and I think this baby already is manifesting. We've had very bad luck with type 1s. They're just very affected, you know, but we'll talk about treatments. So this is a classic case this is the organization Cure SMA. It's an advocacy group of a baby with SMA. So you see we call it frog legs, right? So the legs are abducted because they have weakness of adduction at the hips. So they're splayed out. They're all out, the legs, right? You see over here, he can't pick his arm up because he's got proximal weakness. With SMA, any type, there's proximal weakness. Obviously, the more affected you are, the more weakness you have. It's proximal and distal. And then you see over here, right, they're picking baby up and you see how he's flopping over. That means he's got no truncal tone, okay? And one of the outcome scores that we use in SMA called the CHOP and 10 score, you actually have to pick baby up, obviously not drop them, and see if they're able to sort of extend their spine or not. And obviously this baby can't do that. And you also see the poor neck tone, right? You see his neck is flopping down too. So this is a hypotonic baby. It doesn't mean he has SMA per se. It just means he's very hypotonic. So if he had congenital myotonic dystrophy or congenital myopathy, you can also be very hypotonic, right? But if you have a very floppy baby, you definitely want to think about SMA. So type 1 is the most common, unfortunately. It's about 60% of all patients. They're usually normal at birth. And then at some point in the next 6 months, they don't gain milestones, and then they start losing milestones. So hypotonia, flaccid paralysis, poor feeding, poor head control, and they can't sit without support. Now, one of the giveaways is the tongue fasciculations, which we frequently will see in SMA type 0 and type 1, not necessarily in types 2, 3, and 4, but definitely type 0 and 1. So it's very important to try to look. But on the other hand, though, as many of you guys have seen on your PEDS neuroblock, it's not so easy, especially on a baby, to look in their mouth, especially look at their tongue. So it's very important. And we had a very sad case of a baby who ended up in Kings County in the pediatric ICU, who was about 8, 9 months, and basically had started to lose milestones at age 3, 4 months, and was a floppy baby, and was getting weaker and weaker, and then eventually got pneumonia because they had ventilatory weakness, and had actually been in another hospital in New York City. But the resident erroneously told the attending that mom had been screened as a carrier for SMA and was negative. And it turned out that was not true. And then ended up at Kings County, and we didn't know what the weakness, what the cause of the weakness was. So baby had a lot of trouble breathing, eventually got a tracheostomy. Once baby got tracheostomy, we were actually able to look inside and see the tongue. And I think it was actually Dr. Krakow, was the attending, and she saw the baby had tongue fasciculations. This was before newborn screening. This was about 2014 or so. And obviously ordered the test for SMA and found out the baby had SMA type 1. The trouble is the longer you wait, the less effective the therapies are. So this baby did get treated, did benefit, but didn't do as well as if they obviously had been treated more appropriately. So this is type 1. In type 1, you get what we call paradoxical breathing and a bell-shaped upper torso. So when they breathe, you can actually see, because the intercostals are weakened, the muscles, you get this paradoxical breathing. So instead of expanding, it sort of comes in when you're trying to breathe, and you get this bell-shaped torso, this round upper torso. And you could see that just looking at them. So we had another type 1 SMA who was about 3 weeks after birth and had older siblings with SMA. So we already knew there could be a problem. And this was, again, before newborn screening. Mom brought him into MDA clinic. He had paradoxical breathing. So I actually grabbed the pediatric pulmonologist, who was luckily walking down the hall. We walked together and we agreed it was paradoxical breathing, and he was a type 1A. So he was a very affected type 1, even before a month of life. And we started treatment for him, actually with Spinal, which we'll talk about in a few minutes. And it turned out Dr. Krakow had actually treated his 2 older brothers who had died of SMA, probably about 10, 12 years before, unfortunately. So, and again, you can argue, why do if parents didn't do genetic counseling? That's a whole other story. So in type 1, they have bulbar involvements. I already mentioned the tongue fasciculations. They have poor suck and swallow. And because, again, there's decreased airway production, you get more aspiration pneumonia, which is what happened with this baby I just mentioned. And, we talk about the need for permanent ventilatory support, definitely by 13 months, and then death is usually by 2 years. Now, type 2 is the intermediate form. That's about a quarter or so of SMA. Usually it's presenting at 6 to 18 months of age. So they can sit without support. Very rarely, if you could stand with leg braces, but they really can't walk independently. They develop contractures. They develop scoliosis, which is a huge problem for SMAs 2 and 3. And it turns out now that SMA type 1s are living longer, they're developing scoliosis. So a lot of these get scoliosis surgeries because otherwise, without it, if you have very bad scoliosis, if you remember, you actually can lose lung fields as the scoliosis worsens and worsens, and you start bending more and more. So actually, it's important to fuse the spine before that happens. These patients can also have tremors when they grip things or extend, and that's from weakness. Very rarely do they need G-tubes. They can have respiratory issues, so frequently they're on BiPAP at night, but they don't usually have aspiration problems like in type 1. So type 3 is the least severe pediatric one, and there's a lot of heterogeneity of symptoms. So all of them achieve milestones, right? They sit, they crawl, they stand, they walk, but some of them can start losing the milestones in preteen years and eventually need wheelchairs. But others can make it to adulthood with very mild kind of weakness. It's very variable. And again, the weakness is always proximal and progresses distally very slowly in both the arms and the legs. And some people, it may, year to year, you may not even see very much difference. We had a young woman who was, I started seeing her when she was 14, 15 with SMA type 3 and started to have more and more problems with walking. And for reasons that are still unclear to me, she and mom both refused treatments. They were afraid of Spinraza, which we'll talk about, which requires intrathecal injection. But even with the new therapies that are oral, I don't know, they're worried about birth teratogenicity and things like that. So she actually lost ambulation because she wasn't treated. And that, again, can happen with type 3. So she's in a wheelchair. She's alive and everything, but she's 20 now. And she's in a wheelchair, and if we had treated her, probably not. So again, they develop scoliosis. They have near normal survival. Probably of these patients, a minority are the 3A that have an onset earlier on. The majority are probably 3B. So, they're able to walk longer because they present later in terms of the disease onsets. So the later you present, obviously, the less affected you will be later on. And then again, this is the one for everybody in the room, except I guess the peds, who's peds neuro here? Yeah. So basically, these are ones who present in the second, third, or even fourth decade of life, very mild motor impairment, no respiratory or swallowing issues. And a lot of them, can make it even to the 50s, 60s with still walking. So this one, again, you just need to think of the diagnosis. There's no easy way around it, because again, it can mimic so many other things. So how do you treat SMA? So we'll talk about the medications that we use in a second, but in terms of the other systems that are affected, you need some kind of cough assist machine frequently because these patients can't expectorate, right? In order to cough, you need to generate, right? Exhale forcefully. If you can't do that, and that's the first thing to go when you have ventilatory weakness. So this is true for any neuromuscular patient, right? You get diaphragmatic involvement, the first thing you can't do is exhale forcefully, you lose the cough. You lose a cough, you can't clear secretions. You can't clear secretions, especially as winter rolls around, right? You then develop pneumonia. So frequently we'll use what we call a cough assist machine, or a insufflator exsufflator is another term that people use. So you guys should at least know what that means. Obviously, the respiratory people know what it is, the pulmonologists, but it's important. And then obviously, if it's a type 1, they may need trach and vent. If it's type 2s and 3, they have some kind of positive pressure ventilation, whether it's BiPAP or non-invasive ventilation, especially at nights. For the type 1s, they need a feeding tube, not usually for the other types, so they're following with GI, which is what we do here. I already mentioned the scoliosis, so they really need to follow with orthopedics. Unfortunately, bracing does not work. You could put people in a body brace, a TLSO, it will not help because you have the truncal weakness, gravity is exerting its effects on the spine, and it's just becoming more and more, scoliotic. So you can't brace to prevent that. You basically need mechanical fusion, which is what the surgery is. And then I was going to show you guys a picture of that, but I don't think I did. And then because many of them don't walk, they have decreased bone density because they're not weight bearing. So they need DEXA scan, calcium supplementation, etc. The good news is the heart's fine, unlike other neuromuscular diseases. So Spinraza was the first medication that was approved. I'm sorry, it wasn't Christmas. It was right before. It was Christmas weekend, 23rd. I remember it because the grandmother of one of my SMA type 2 patients actually called me literally 2 hours after it was approved by the FDA. 2 hours, I'm not exaggerating, 2 hours. And she asked if I was going to start giving it. And I was like, you mean the one that we have to give intrathecally? I said, let me think about it. But by that April 2017, we were already giving it. We were the second site in New York City to give it. Not the first site. Columbia was the first site, but in fairness, they were part of the original clinical trial. So we were the first sites. And the resident I injected it with was actually one of the Peds Neuro fellows. And this is a medicine that's $125,000 a vial. And you give a loading dose, which I mentioned here, 4 times in 2 months, and then it's every 4 months. So you do the first year, it's about $750,000. So you're sort of looking, and the resident was like expecting, I guess, I don't know, a vial with like gold or gold flakes or something. And it's a clearless liquid. It's really it's a very anticlimactic. So she's looking at it and she's like, can I take the box home with me? Because she wanted to show it off. And it's literally, I don't think I show you guys a picture, but it's like, so you're doing it, it's like a lumbar puncture for everybody in the room. But the difference is you actually take out 5 cc's, but then you screw in the syringe and then you put in 5 cc's of the medication. So and it's literally, you just draw it up out of the vial in a syringe. It's that simple. You don't have to reconstitute or anything. But because it's $125,000 per vial, I would not let the resident draw it up, because what if you like lose a cc or something? That's like $50,000. You know, that's like, you know, half your salary for a year, right? So, or can you imagine if, God forbid, you know, a resident like, whoops, you know, dropped it on the floor, you know? It turns out the company will give you extras if that, God forbid, happens, but yeah. So, they actually looked at the benefit of this medication in the 2 populations, in the type 1 SMA and the type 2 and 3 SMA, and these were the 2 trials. And it did show significant benefit, not just in the motor scores. In other words, what were they able to do from a motor perspective, but also it helped in terms of survival for the type 1s. It helped in terms of the lack of ventilation, lack of need for ventilation for the type 1. So it worked on many different levels. So it's a very effective medicine. We still use it. We don't really do it very much here now for 2 reasons. One is, if it's going to be given to a little kid, they need to be sedated, not like a baby, but like a 3-year-old or a 4-year-old or a 5-year-old. And then the trouble is once you fuse the spine, and I don't know if you guys have ever seen an X-ray on somebody with a spinal fusion, it is impossible to give it intrathecally because the anatomy is so messed up after a spinal fusion. So the way we were giving it via fluoroscopy or CT. Vin, who just unfortunately left county, we used to do it together there, and he would use CT guidance to give it transforaminally. The risk of that is, what else is in the foramen? You got roots. So if you go too far, you're going to hit a root or inject it into a root, which is obviously not a good thing that you want to do. So it's tricky. And even with CT guidance or fluoroscopy guidance, it's not that straightforward. It sometimes can take 30, 40 minutes. And again, even if it's an adult patient, it's very uncomfortable being on the table. And obviously you're being exposed to radiation, right? So I would be there because a lot of the times the radiologist would want me to actually push the medicine. You know, they would get the needle in. So I'm sitting there in an apron, you know, just like, you know, waiting for 30 minutes as they're playing around. And sometimes we luckily never missed, but one of my patients had to go to another hospital for insurance reasons, and they actually weren't able to get it. So the patient was not very happy, as you can imagine. So we don't do these as much anymore. We usually refer them out now if they're going to need it, because we just don't want to do it under fluoro. We don't have the capability here and across the street. Yeah. In fact, Kings County actually kicked us out. So they gave orders we were not allowed to do it anymore because it was not bringing in enough money. So we're actually not allowed to do it in Kings County anymore. So how does Spinraza work, or nusinersen? It's what's called an exon skipping technology. So this is the SMN2 gene. So remember, they don't have SMN1. So what happens is you give this medication. Now, normally, if you don't have the medication, when you splice, you have your transcript over here. When you splice, a lot of the times you splice out exon 7. So you end up with a protein that lacks exon 7, and that protein is unstable and eventually will degenerate. And again, remember we said you need SMN2 if you lack SMN1. So if SMN2 disappears, you're in trouble. So it turns out that in many SMA patients, 10% of the time you will include exon 7. You won't splice it out, but 90% of the time you will splice it out. So what happens is that Spinraza shifts this. And what it does is 90% of the time you include exon 7, it blocks the splicing site over here so you don't splice it out. So 90% of them have exon 7 and it's a viable protein and therefore can rescue the phenotype. And then only 10% lack exon 7. Okay, so that's why we call it exon skipping, because we don't want to splice out exon 7. Okay, we want to include it so we prevent the splicing out of exon 7. So again, there are barriers, right? Obviously insurance, you need anesthesia, fluoroscopy, and travel. And this is not quite patient with it, but this is basically what you'd be doing. You have the needle in here, you attach the syringe, and you sort of push it in. It's very similar if you were giving intrathecal antibiotics or something like that. It's the exact same concept. So there is a competitor called Risdiplam or Everestate. It's basically, yes.
How much does it increase when curative or is it like?
It's not curative, and we only have data going basically for like 5 years. But I would say of the people surviving, I'd say it's probably something like 80–90% survival thus far. Now, are they going to make it to age 15, 20? Nobody knows. But are they making it to age 5 or 7? Absolutely. So my oldest is 7, I think, who has type 1. She just had her 7th birthday party. I think she's 7 because I gave it to her in 2000. I think it was 2017. So she would be about 6.5, 7. So maybe she's just turned 7. So, and you never would have seen this. I mean, you speak to any attending who, finished residency before in the last, before 6 years ago, and like, you just didn't see this, I mean, it's mind blowing. That's the only way to describe it. They literally would die. Now, I will tell you, when I did sabbatical in England, I did see an 11-year-old with type 1. I don't know how the hell he made it to 11. That's like a world record, but 90–95% used to die by age 2. So Risdiplam, it's a very similar mechanism of action, but instead of it being intrathecal, it's IV. Sorry, it's oral. Obviously much easier to use. And again, it's been looked at for type 1 and type 2s and 3s, and it was approved about a year ago. So many of our patients, we've been transitioning them from Spinraza to Risdiplam just because it's easier to use. They're roughly analogous in terms of efficacy. Okay, and they're looking at like I said, all ages, not just pediatric, but even adults. And then this is gene therapy. So this was the second medical indication for gene therapy in the US. So the first one was for one of the retinal diseases. SMA was the second indication for gene therapy. So we actually have successfully given gene therapy at the center. Again, I think we were number 2 in New York City, but that's still pretty good. We actually gave it in 2020. And this was discovered by Jerry Mendel, who's at Children's Nationwide Hospital. And he's actually also just discovered, you guys may have read about gene therapy for Duchenne, just got approved because of Dr. Pavlakis, not only because of Dr. Pavlakis, but he was on the committee that supported it. Dr. Mendel also discovered that too. So Jerry Mendel has done more than I will ever do in my lifetime. He's done, in a year. So he's actually working on limb-girdle muscular dystrophy as well in terms of gene therapy. So this was published in 2017. And what he does basically is this gene therapy is you actually give the missing SMN1 gene and you use an AAV9 vector to do so. So it's a pretty safe medication. There are potential side effects. So I don't think I get into those. It can cause a transaminitis, and actually they just had 2 cases of hepatic failure in Europe. One was in, not Europe, well, one was in Uzbekistan, one was in Tajikistan, and they basically developed severe hepatic failure and died. 2 different cases. So now they just changed the monitoring requirements that you have to check labs like weekly for 3 months after you give it, LFTs and things like that. It also can sometimes activate the complement system, and they've had a few instances of it causing hemolytic uremic syndrome and renal angiopathy. So it also makes you a little nervous too. But again, if you look at the benefits, this was one group, one of the initial groups of 15 patients, 2 of the 15 walked independently. 11 out of 12 sat up, unassisted. So there's the potential for people who get the gene therapy to truly modify the disease. We're talking about sitting, standing, and even in a small percentage, walking. And when Jerry Mendel showed the video, it was 2016 or 2017, he showed it at one of the big neuromuscular meetings, and it was a type 1 SMA. And again, remember, type 1 SMA, these are the ones who die, right? These are the ones who never sit without assistance. And you saw this boy walking and maybe even running, and people in the room were literally crying. I mean, and neurologists, we're not really known for our emotionality, right? We're not exactly the, touchy-feely kind of people, right? And there were people in the room, I mean, grown men and women and older. I mean, some of them had, been practicing for many decades, who literally had tears because here you have a boy walking with a fatal disease where you're never able to even sit up. I mean, you can't ask for anything more. I mean, I wouldn't call it a cure. And we don't know ultimately, we do know the benefits have been maintained for at least, I think, 4-5 years. We don't know beyond that. Now, the good thing is that you don't really have a lot of division of motor neuron cells, because that's always the danger of gene therapy. If there's a lot of cell turnover, you're going to lose the benefits. Because I don't know if I mentioned this, this is given actually as an independent vector. It doesn't integrate into your DNA. Okay, so this is a vector that comes in. Sorry? It's AV9. It's a virus, AV9 virus. And that's actually what seems to cause, those side effects that I mentioned. It's the AV9, it's an adeno-associated virus that seems to trigger an immunologic response. It's not the same as adenovirus. So when I was a student, they used adenovirus for different diseases, and that actually caused fatal death in 1998. So they moved away adenovirus and they went to AAV9, adeno-associated virus. The one for Duchenne is also an AAV, but it's not AAV9. So, but other people are using AAV9 for Duchenne as well, other programs. So AAV9, it gets into the cell, it sort of stays there. It doesn't incorporate into the regular chromosomes. You don't have to worry about permanent mutations, right? These aren't germline mutations, nothing like that. Okay. But to be honest, I wouldn't even care. I mean, we're talking about, a fatal disease. I mean, are you crazy? But whatever, you don't have to worry about that. So that's, I would say, standard of care. And the trouble is, it's only approved, it's only given, it's weight-based, so it's only given up to 20 kilograms. So basically, it's approved for ages 2 or less. So, and again, for all of these therapies, Spinraza, Risdiplam, Zolgensma, gene therapy, you want to give it as soon as possible after birth, especially for type 1, because especially type 1s, motor neurons are dying every day, right? And remember, you lose motor neurons, you don't make new motor neurons. So whatever you've lost is gone permanently. Type 2 and 3, you have more time. So the trouble is this baby, this type 1 that I said was referred to me through newborn screening. So we were like, okay, we're all set. Let's give him gene therapy. Let's just tee him up and there we go, right? And again, the gene therapy, again, it's $2.15 million. And again, you'd expect an IV bag with like gold flakes and the whole kind of thing. Again, very anticlimactic. It looks like just IV saline. Okay, the difference is IV saline is $20 and this is $2.15 million. It's a one-time infusion. Remember, it's a gene therapy. And the trouble is that it's because it's a viral vector that you're using, this AV9, you have to test for antibodies against the viral vector. If you have antibodies against AV9, you can't give it, right? Because your body will fight it off like a virus, it won't work. And it may even cause an anaphylactic response. So the trouble is this baby, we tested him, bad luck, his antibody titer is off the charts. So now it could be from mom, because remember, you can get transplacental transfer of antibodies. In fact, that's usually what happens. So we're actually trying to track to see if he will clear these antibodies. And if he does, then you give him the gene therapy. Meanwhile, we're actually giving him the risdiplam. We could have done Spinraza, but just such a hassle. Even though he's like 1 month, it's not that hard. You can just bring him in and you don't need sedation. You can just do it, but because you have to do 4 times in the loading period, we just decided to give him risdiplam. But if he clears the antibodies, the AV9 antibodies, then we will give him the gene therapy. Well, no, that's a debate. So when I gave gene therapy, we did not keep people on the medication. So in other words, if they were on another medication, we put them on gene therapy and then we tracked them over time. If they worsened, then we started one of the other medicines, either Spinraza or risdiplam. Now, some people don't care. They try to do both. The trouble is insurance will almost never allow you to do that because Spinraza is $325,000 a year. Once you've given it, $750 the first year, and then you're adding $2.15 million. You do the math. Right? You just broke the bank, right? You just spent $3 million for one person and insurance is not happy. So we've had insurance companies tell us, you give gene therapy, that's it. You don't get any other therapy. It's like one-time deal. I don't know if legally they're allowed to say that, but they say that, No, and it's an issue because, until the last 8 years, neurologists were not giving medications that broke the bank. I now was told by the pharmacy that the medications that I prescribe cost more money than any other doctor in the hospital. And I can tell you when I was a neurology resident, that was not my goal in life, but 2, I never even suspected that would be my goal in life. Okay, because if we're giving Spinraza and risdiplam and gene therapy, and then exon skipping medicines in Duchenne and all the new myasthenia medicines like Vyvgart and Solaris and Ultomiris, and the list goes on, then you see that I'm even beating the oncologist, which let me tell you, I never expected to see in my lifetime. So I'm single-handedly, wrecking the American healthcare system. I should take a bow, right? I don't know what to say. These are the different outcome scores that we use. And again, it's just when you read the article, the clinical trial, this is what we're looking for in the clinical trial. Or if you're in NDA clinic with me and you see like, why am I doing all these weird things, picking up baby and holding him prone and supine and all these other weird things? It's because these are the outcome scores they decided to use to show that there's actually motor benefits. And and then, for obviously for a non-ambulatory patient, how can you test walking, for example, right? That doesn't work. So then we actually look at what's called the RULM, which looks at what can you actually do with the upper limb. And if you ever want to entertain yourself, if you just Google RULM and just watch the video, it's the most bizarre group of tasks that they ever came up with. And actually, the people came up with it. It's like you have to draw a line, you have to pick up a cup, but it has to be like a 10-ounce cup, not a 15-ounce cup. It's literally the most bizarre. There's not even a kit. You actually have to go to Amazon and order the individual components. It's just beyond bizarre. It's beyond bizarre. So I think it was like an OT or PT who like either had way too much time on their hands and or were drunk, just decided to come up with it because like it's just a random collection of stuff. So there is one new therapy that's coming out. So remember I showed you guys, I think it was, what was it? Monday or Tuesday, the approach to myopathy. Remember I showed you guys the super cow and the super boy, right? With the big muscles. And they said they lacked myostatin. So the other therapy now people are looking at is anti-myostatin technology. So even though the main problem in SMA is motor neuron pathology, not muscle, but obviously you lose muscle from neurogenic atrophy, right? Because the motor neurons are dying, the muscle, therefore it becomes atrophic. So then somebody came up with the bright idea, what if we give something to make the muscles larger? Now, when they actually asked me to join the trial, I was like, this is the dumbest thing I've ever heard. Because they said, don't you guys know the pathology is the motor neurons? And they said, yes, but, and I said, okay, whatever, it's not gonna work. Turned out in the phase 2, seemed to work for SMA types 2 and 3, not type 1. But types 2 and 3, and it worked in people who were being treated with already other therapies. So they weren't naive to treatment. They were getting risdiplam or Spinraza, and then they added this on. And they were also being treated with risdiplam and Spinraza earlier, in life. In other words, they didn't wait too long to treat them. So it turns out I was sort of right and sort of wrong. The reason it works is because it's not addressing the primary pathology. You have another medicine doing that, Spinraza or risdiplam, but it's an add-on medicine. So it's helping the muscle because the muscle's still not normal, right? Because even with these other treatments, the motor neurons are still dying, right? With Spinraza and risdiplam, it doesn't stop the disease completely or reverse it. But this new myostatin inhibitor is able to sort of help the muscle get a little larger, get a little more functional, and then maybe help. So this is now in a phase 3 trial. And if it shows benefit in the phase 3 trial, we actually may add that. It would be an add-on therapy to the existing therapies, either the gene therapy or Spinraza and risdiplam. So people have tried, all of the other small molecules, but they haven't really panned out. So, I would say in 2023, if you're born with SMA, the good news is A, you will be diagnosed promptly. Again, whether you're type 0, 1, 2, 3, or 4, in 45 of the 50 states, and I don't know the 5 states that have refused to do it. It's probably, well, anyway, I won't say anything, I have my suspicions. And then if you're diagnosed, you could be treated promptly with gene therapy. And if you can't have that because of your antibody status or something, then you still have risdiplam and Spinraza, which are very good therapies. And I don't know, again, I know obviously you asked what the ultimate survival is. We don't know what that's going to be, especially for type 1s. Type 2s and 3s, there's no reason you can't make it into your 60s, easily 50s and 60s. Type 1s we'll have to see ultimately. Okay. So I'll stop there. Any questions? Yes.
Slightly more ethical question.
Sure.
I have no conflicts of interest.
Okay.
But like you mentioned, the girl that the mom refused.
Yes.
And then she eventually became on ambulatory. Generally speaking, when we're inpatient in the hospital and patient has some whatever it may be and consider life-saving
Yes.
therapy, do it.
Yes.
In this case, you have a pediatric patient.
Yes.
Potentially with a life-saving therapy, it's not necessarily just going to die tomorrow.
Right.
So has there been talks or consideration of like forcing these patients to get these medications?
Well, this is when you theoretically can pull in ACS, right? And you can actually, agency for child services, right? Because you can argue that the parents are not providing appropriate medical therapy. We do that not infrequently in pediatrics because the child is not able to assume decision-making capacity. And if a parent is withholding therapy, and this is not just for SMA, this is for many, many, many therapies out there. It's come up even in Duchenne. I've had this happen. Yes, that's a reason for ACS to take away a child from the parents because they're not receiving it. This case, you can argue, is different because it was not life-saving. And in the beginning with Spinraza, you can argue it's an invasive procedure, risk-benefit. The thing is, I think when risdiplam came out, she was already 18. So she already had decision-making capacity. And then she and mom, the two of them have a relationship. They refused together. And at 18, I mean, you guys have seen many adult patients you have the right to make dumb decisions when you're an adult, right? No, I mean, that's, you don't say you've lost decision-making capacity. So that when she refused. But yes, if you had an SMA baby and the parents were refusing treatments, then yes, that would be a reason to get ethics involved. But yes, you would override their capacity. But if it's type 1, or I would even argue type 2 or 3, because with a type 2 or 3, or even a type 1, if you treat them promptly, you have, they have the chance of having a relatively normal motor developments, so there's not bad odds for them to even stand and walk. And if you take away that right from them, you can argue you're violating, their privileges. So absolutely, I mean, I did speak to Dr. Geary about this case. I don't know if you guys, have worked with Dr. Geary. She's pretty hardcore. So she was like, you call ACS now, but then there's an issue with the relationship between you and the patient. It's not always so straightforward. But yeah, no, it's an issue. And that still sticks with me because I'm convinced if she had Spinraza and then risdiplam, she'd still be walking. Now, would she be walking 20 years down the road? I have no idea. But would she still be walking currently right now, a few years later? Yeah.
We have a question here.
You remember the Sleep Brothers? One was diagnosed with-
Yes.
He ended up getting the gene therapy.
He did not. No, he did not. But he got the oral.
Yeah.
He got the oral. Yeah, he got the oral therapy. Yeah. So, and again, probably the gene therapy, if you look at the data, is probably the best. We're talking about if you give it early on, or all the therapies early on. The best is to give it when they're asymptomatic or pre-symptomatic. You get extremely good results from that. Right. So, that's the best to give. But you have all these three options. So, we're talking about a disease, you went from 0 to 3 therapies, and we're probably going to have this 4th therapy as an add-on too, which is just incredible, since 2016. So we're talking about not even 10 years. No, it's too late for many of me to convince you guys to go into neuromuscular, as I'm looking at the seniors in the room, right? But some of the juniors are here, right? So, guys, I mean, a student once said to me, like, there's not much you can do in neurology for patients. And I'm like, now look at this. We can make kids walk who couldn't sit before. Like, what else do you want us to do? We're giving gene therapy, for God's sake, literally, for God's sake, So I don't know of any other branch of neurology that is reversing disease, right? Nobody's undoing strokes. Last I checked, right? Nobody's undoing spinal cord damage, right? Nobody's undoing epilepsy, right? We're literally undoing it or really meaningfully modifying it. So, and there'll be more talks. I promise you. We're going to talk about muscular dystrophy next week. 5 years from now, there's going to be new therapies. It's just like an SMA talk from 5 years ago is outdated. So it's moving that quickly. So again, it's just something for the juniors to think about. Okay, so we'll stop here. So thanks everybody for coming in person and otherwise. Glad I'm able to end on a happy note for once.
Myostatin inhibitors can be like the new black market steroids.
It's funny you mentioned that, Dylan.